Thank you. I feel a little silly talking to this size of group with a mic, but but we're recording here, so I'm going to keep on going. And so I'm going to take advantage of the fact that we have a little smaller group in here and ask you if we can just take a moment, if we can just kind of quickly go around, and if you could just tell me your first name and tell me what you do, what your job is. Would you mind starting?
My name is Sarah Williams. I am the supervisor for the outreach program with immunizations at the City of San Antonio.
Immunizations, especially. Okay.
And I'm in the Family Pack program, but I'm a health program specialist. There's a lot.
Okay.
Vaccines is what we do
All right.
for the community. Stephanie, I'm a program officer. I manage grants at a nonprofit here in San Antonio. I'm also a consultant for another nonprofit dealing with health literacy projects.
Okay. Great. Great. Let's go to the back.
I'm Cynthia, and I'm a registered nurse working with the Nurse Family Partnership.
Okay, Cynthia, registered nurse.
I'm Joelda. I'm also registered. Joelda Pinilla, registered nurse, and I'm with the Nurse Family Partnership.
Okay. Great. Thank you.
I'm Rachel Santos. I'm a case manager at the San Antonio AIDS Foundation, and I work primarily in medication assistance.
Okay, so a lot of medication work.
I'm Margaret. I'm a pharmacist. Study at pharmacy and we're located in San Antonio.
Oh boy. Okay. We got a pharmacist here, so now I'm really got to really watch what I'm saying. I have to actually stop here for just a second. I'm going to be talking today about a lot of things, but one of them is about a project that we're involved, a pharmacy-related project that we're involved. And this is the first time that I've really ever had an opportunity to work with pharmacists directly, other than handing over prescriptions. And what a fantastic group of people to work with. It's just been really a pleasure to get to know some. So, okay, if we could go to you.
Hi, my name is Letitia. I am a public health associate fellow with the Center for Disease Control and Prevention, assigned to San Antonio, Texas. So I'm at the Metro, and I'm 5 days in working with the Community Health Division
Meaning you've had this job for 5 days?
for 5 days, 5 working days.
Wow.
Business.
Okay. So you're really experienced. Yeah. All right. Yes.
Hi, my name is Tiffany. I am a 4th-year pharmacy student at the University of Texas at Austin.
Okay. So almost a pharmacist.
My name is Stephanie. I'm also almost a pharmacist.
Okay. Excellent.
I am Victor. I'm also almost a pharmacist. And I'm Sam. I'm a pharmacist with University Hospital.
Okay. Great. All right. So thank you for coming. I appreciate your info. I can see why some of you have a special interest, and others of you will maybe become a little bit more obvious as we go along. I've got some information to present. I will have some questions to ask you. We'll have a little activity thing that we'll do later. But please, because we're a smaller group, at any time, if you have a question or comment, please feel free to shout it out. You don't have to wait till the end. Be better off to deal with it, or a story to tell, which in this world of pharmacy is where a lot of the good work gets done, is by sharing some of the stories that people hear. So we're going to talk about communicating about medications, a health literacy challenge. And we're going to talk a little bit about what is the problem with medication communications, specifically what is the role of the label and what is the big deal about the label. I'm going to share 2 case studies, one which relates to a medication workshop that is something that could be replicated if you choose to do so. And then another case study that deals with a project to make labels easier to understand. And then we're going to end with a little bit about what you can do, what some of the things you can do maybe as a result of hearing some of the information that I think that will be interesting to you. So we're going to start with, this is a gentleman named Hashem Zybak. Hashem is a pharmacy manager at a pharmacy called Hyatt Pharmacy. This is located in Milwaukee. There are 10 different sites of this pharmacy. Primarily, it's located in low-income areas in Milwaukee. And he recently spoke at a medication label summit that we had in Wisconsin and shared this story. And I want to have him tell it in his own words because It's, what I think of it is this is why we do what we do.
One of my favorite stories. I was visiting a patient in her house, doing her medication therapy management, going all over all of her medications. She was recently discharged from a hospital, and I asked her to show me how to use her Spiriva capsules. And the directions were inhale contents of one capsule every day. So she did initially the right thing. She opened the device, put the capsule in there, and then she started inhaling. And I'm like, how about piercing the capsule? She never pierced the capsule. So since she got out of the hospital, she's been just inhaling nothing, just regular air with no medication in it. And even though the directions were what I thought was clear, inhale the contents of one capsule, and that's what a lot of us pharmacists put on the label, she did not do it properly.
So I'm sure that every pharmacist has a story. So just before I go on, and I know that you pharmacy students, or you're out working actively in pharmacies now. So anybody have a story you're willing to share with me about where it was a problem with communications about medicine?
Recently, we had a client take vitamin D, and it says on the bottle to take 1 capsule weekly. So, we went through it, I counseled him, explained to him how to take it, and I can do it as a teach back, so tell me how you like to take it. I'll take it once a week. He returns 5 days later, he says, I need a refill. I said, what do you need a refill? My vitamin D, you only gave me 12 capsules, I took 1 a day. So, I said, we got over this. Oh, I remember now, he did say once a week, but, and it says on the label.
So he wasn't paying attention to what it said on the label. He was just taking it, what he remembered as being, okay, vitamin D story.
I remember there was an example of a female patient who was prescribed NuvaRing, which is a vaginal ring for birth control, basically. And the directions just said, use 1 ring every month. And she was actually wearing it on her wrist.
I hear a lot of stories like that, and it's the kind of thing that your reaction is, well, I mean, how dumb was that? But, this is the reality of things that people interpret, and one of the things that we find is that people who have lower health literacy tend to interpret things very literally. So you really have to be careful because what they hear you say may be something entirely different than really what you're thinking is the case. So those are some great stories. I mean, that's the kind of thing that why we really need to focus on this. So now let me ask you to do a little quiz here. So here's a medication label, the top, and I want you to take a look at that and tell me, don't say the answer yet, how many do you take in a day? So what's the answer? How many think the answer is 1? How many think the answer is 3? So the answer is 1 because it's 1 tablet daily. Now, this is confusing. But there's nothing that shows it better than this was actually a study that was done at the VA, which the VA did some new labels. And they asked people this question. 42% of the people answered 1, but 38%, almost the same number, answered 3. Because it's confusing. So again, it's what's on the label. And as you have so greatly explained, just because the pharmacist explained to you how to take it doesn't mean necessarily you're going to remember how to do that, which gets to the importance of the label. Okay, this one, what's the maximum number you can take each day? How many think it's 4? How many think it's 6? 8? 12? Okay, think about this one for just a second. So you can take it as soon as 4 hours, as early as 4 hours, and you can take as many as 2 tablets every 4 hours. So 2 tablets, and there are 6 4-hour periods, so it's 2 times 6 is 12. But look at how much math that requires. You got to figure out how to do that, and I'll leave it to you, pharmacy people, whether that would even actually be appropriate to take 12 of those in a day. Seems a bit much to me. So what I'm getting at here is the prescription label and how confusing it is and why it's such a problem. In the world of literacy, there are 3 kinds of literacy. There's prose literacy, document literacy, and the quantitative or numeracy. So prose literacy is like reading sentences, reading books, writing a letter. Document literacy is like looking at a chart and figuring, like a nutrition label, for example, and figuring out information. And then the last one is quantitative literacy, or numbers. Now, the problem with a prescription label is it requires skills in all 3 of these. So you've got, whoops, let me go back up for a second. So you've got prose literacy, they've got the directions for how to take it, which is usually kind of like a partial sentence. You have to understand that. You've got document literacy, because you have to look at a label, you have to figure out what are the different things, where is that, what number is that, what date does that go to? And then you've got quantitative literacy, like what I just had you do, calculate how many pills can you actually take in a 24-month period. So it requires all 3 of those things. And we know from a lot of research that people struggle with those types of literacy. So in prose literacy, we've got roughly 43% are in the lower categories of literacy, prose literacy. Document literacy is a little bit better, but look at quantitative literacy. Over half of people struggle with quantitative literacy, or the numbers. This is the math. What I always used to refer to as the I Hate Math Club in high school, the people that really didn't like math. So it's really a challenge to figure out, what seems like it should be just a simple thing. Now, prescription literacy, we talk about a lot of different kinds of health literacy, we talk about computer literacy, we talk about a lot of different kinds of literacy. But actually, prescription literacy is another one, and in the world of the AHRQ, the national organization, they refer to it as pharmacy health literacy. But it's really a big issue, and it involves really the understanding of how to take medication, the intersection of patient safety and health literacy. Now, what we just talked about here, with these stories that you talked about, some of them maybe didn't end up with harm, but something could end up with harm. There was a case as part of our work, we have people tell us stories all the time, and one woman talked about how she was given a prescription that said that she was supposed to, on the label it said take 1.5 pill 3 times a day. 1.5 pill 3 times a day. She took 1.5 pills 3 times a day, because there was the number 1 and then there was the fraction half. So she looked at it, and that was risk. That's the intersection of health literacy and patient safety right there. And that's why we're talking about this. Medication errors are more likely to be with patients with lower health literacy, and we already know from a lot of the other health literacy research that there is an association between low health literacy and poor health outcomes. So why is communication about medications so hard? Why do you think?
Well, one thing is just the language, because when you're talking to people, your peers basically, you're talking in medical jargon a lot of times, and then having to switch to simple language with the patient, it takes some getting used to for sure, because you don't want to be condescending and, dumb it down, I guess, but then at the same time you don't want to confuse them. So that's really hard to communicate sometimes.
So in a sense, kind of what you're talking about is trying to figure out what the patient understands or doesn't understand, and what words you have to use, or what explanations you have to use in order to do that. So it's hard to know. Why else do you think it's hard?
A lot of the time we assume that people know more than they do. And so, like you said, we'll say something assuming, oh yeah, everybody does that. when in fact they don't want to speak up because they're embarrassed maybe that they really don't understand. And so then they just leave and we're like, okay, great, we did a good job. And they have no idea what we're talking about. And then the error occurs.
Okay, so a lot of assumptions being made, and you're dealing with the other side of it where people don't want to ask questions because they feel like they feel stupid, like they should understand what you're talking about. So here's just some other things that or some of the reasons that make this so difficult. We don't know what we don't know. So, the pharmacists know the ins and outs of a medication, but they don't know necessarily. So take an example of acetaminophen is a big issue right now because there are so many drugs that have acetaminophen in them, and there are people who are taking acetaminophen, and then they're also taking drugs with acetaminophen, not realizing that basically they're overdosing on acetaminophen. So they don't know what they don't know. And different drugs, different timing. Some of you may have seen there's an video that came out from the AMA that talks about people with lower health literacy. And there's a woman in this video who holds up a little case, and she said, "These are the medicines I take each day." And it was full. It was just full of pill bottles. And she said, "I take this one, I have to take twice a day. This one I'm supposed to take for pain as needed. This one is supposed to be once every other day. And this one," she said, "I can't remember what this one is." She said, I can never remember when I'm supposed to take them, so I just take them all in the morning to be sure I'm done with it." I mean, again, the intersection of patient safety, but it's a huge area. We don't, and then you get into drugs like, what do you call it when you have to, taper. So if you're taking a drug where you're taking a tablet today, and tomorrow for the next 3 days you're supposed to take half a tablet, and then for the next 3 days you're supposed to take a quarter of a tablet. I mean, imagine trying to manage all that. They may not feel well when they're actually taking it. They may feel sick, and it's hard enough to concentrate. Manufacturers change, the colors of the pills change, they get confused, and it's really hard to remember when to take them. Especially if you got difficult regimens or like that. Now, as far as the pharmacists go, adherence is a big issue, right? Is that true? Adherence is a big issue for pharmacists? So adherence basically is, are people taking their medicines, the way they should be? There's an indicator called the medication possession ratio, and you'll hear a little bit more about this a little bit later. But essentially, it determines whether people have a medication in their possession that they should be taking at that time. So, in other words, are they getting refills done accordingly? And there's a lot of emphasis in the pharmacy world about adherence measures and when are people refilling their prescriptions, which is why with certain prescriptions their calls are being made. We haven't heard from you in a while. Do you need your prescription filled? Or why those of us who are on smartphone apps are getting emails that your prescription is ready for refill. So, there's a lot of emphasis in that. And think about the pharmacists as being one of the most accessible healthcare professionals. A couple of weeks ago, I actually did a presentation in New Orleans for the National Center for Farm Worker Health. And they talked a lot about farm workers and who are working, and oftentimes they're moving around from place to place. Or else, even if they aren't, they're in the same area, there aren't very many providers in the area. If they're looking for somebody to ask questions about a medication or a health problem in general, for example, the pharmacist is like the most available person because you can walk in the drugstore, assuming there is one, and ask the pharmacist a question. So it's really an important role. Now, what's the problem with understanding? So in looking at what the problem is, what is the medicine for? People don't remember what their medicines are for. I can always remember an example of one woman that was in one of the groups that we had who she took 5 medicines and she put them into a pill box. She very carefully measured them out to make sure she took them the right ones at the right time. And then she was having some kind of dizziness, and the doctor said, "Okay, for a week, I want you to quit taking your blood pressure medicine." She didn't know which one it was. Now, part of that's a pillbox issue, but even if she'd had the bottle, she probably wouldn't have known what it was either. People don't know how to take it. This whole issue of twice a day, take one tablet 2 times a day, confuses people. When do you take it? You know, and then talk about things that you don't know that you don't know. People kind of assume they know how to take their medicines. But then you ask them, okay, this says take 1 tablet 2 times a day. When do you take it? And they start looking at you like, oh, well, I guess I don't know. You know, some people say, well, I take them when I get up and when I go to bed, or I take it with breakfast and I take it with dinner. Well, that's neither one of them is wrong, but it's not necessarily right either. You know, depending on the medication, you know, some of them you don't want to take right before bed because they keep you awake. Some of them you do want to take before bed because they can make you drowsy. So people don't know how to take it. And what the side effects are, people are concerned about that, but they don't necessarily know, and they don't necessarily read. I mean, you've seen the information inserts that go with medicines, the tiny type that's on there, trying to figure out something there, and potential interactions. You know, and the more people are into herbals and all those kinds of is a bigger issue, because there's a lot of, even in a lot of groups we had, people sort of think that they're harmless. You know, so they think, oh, you know, I don't have to know. I'm taking oxycodone. I don't have to know if my ginseng reacts with that. You know, so there's a misunderstanding with that. And this is a problem that's increasing. So look at the number of prescriptions that were filled in 2017, over 4 million. And now, of course, we got the big opioid problem. And here, of course, we're talking about the legal opioids. And we got this aging population, all these people that are getting older. And who takes the most medicine? Who has the most chronic diseases? Who goes to the most doctor visits? So you've got an aging population, and then you've got adverse drug events that are some of these drugs that are causing problems. And this is just one statistic, the 700,000 ER visits caused by some kind of a drug or medicine problem every year. And the costs, 13 billion is an avoided cost. Think here's another area we could save a lot of money in healthcare if we could get our hands wrapped around this one. Specialty drugs, more coming all the time, adding a lot of cost to the system. The focus on provider efficiency. So we're putting more and more pressure on our providers and the staff to get things done in a shorter period of time, which leaves them less time to really counsel people. I remember giving a talk to a group of physicians once. We were talking about medicines, and I asked them, I said, do you explain, you know, to your patients on how to use this medicine? And they said, no, the pharmacist does that. And I thought, well, I don't think that's not what the pharmacists, I mean, yes, the pharmacists do that, but that doesn't mean that the physician shouldn't do that as well. We already talked about patients don't ask questions, and now we get shorter hospital stays and more outpatient visits, which of course has been going on for some time now. But if you think about all the counseling that's done, used to be done in the hospital about medications, and now you got somebody coming in and going out, and maybe even not even staying in the hospital, when is that counseling done, and who's giving them the information on how to take their medications? I know you can't read this, but this is kind of the point. This is actually one patient's discharge medication instructions. So she was in the hospital, she left, they gave her this was her directions on how to take her medications after she left the hospital. All I can say is I hope this person had somebody with her, had a caretaker or a spouse or partner or somebody who was helping with medications, because otherwise it just would not happen. So those are some of the things that are changing, but what has not changed is what I call the amber legacy, which is just the little amber-colored pill bottles. And believe it or not, these things have been used since World War II without really much change. I mean, maybe they changed the caps a little bit. There was an effort to, anybody ever see the red Target bottles? Okay, which, and you'll actually see a picture of one here in just a second, but the change to the bottles, it was a great change, a really good change that got discontinued because it was too expensive when CVS bought Target pharmacies. So those haven't changed. So now we're going to why do we want to focus on the labels? You know, what is the big deal with labels? That's because they're the most tangible source of information about drugs. So think about how people get their information. You're up at 2 a.m., you have a big pain, you go to your medicine cabinet. What it says on that label is the only thing you got to tell you how to take that medication. That's it. I mean, you don't have anybody you can call. You can't remember what the pharmacist said. So it's really the most tangible source of information. And the second part, crucial line of defense against medication errors in an adverse drug event. So again, what that label says may be the only thing that's keeping you from taking a medicine wrong that could truly harm you. So take a look at these medicine labels. And I don't know if you can actually read that or not. But I'm going to read the top. Every night before food, once daily, to be taken 4 times a day, 3 times a day, every 3 times daily. Daily, take 1, take 2, take 3, 1 or 2. Now these are actual labels. Now yes, this is a bit exaggerated. You know, they aren't all like this. But look at the one on the bottom. Inhale 2 puffs by mouth every 4 hours rectally. How do you do that? Not sure. I mean, it's a big problem. There's a lot. These are just extreme examples of confusion on labels, but just to kind of show the problem. And there's been quite a bit of research that's been done with medication labels. This one, they actually asked people, almost 400 people, they had 5 medication bottles, and they asked them how they would take the medicines. And in this case, they found that of those 5 prescriptions, that 61% of people who were identified with low literacy got at least one of them incorrect, one of the 5. But I think kind of even more interesting is the second statistic there, which is of those with adequate literacy, 38% still got at least one incorrect. So people are screwing up medicines. And it doesn't necessarily mean that they have low literacy as the problem. Now, the same study also looked at an issue of how you explain you're taking medicines and how you would demonstrate it. So it asked people to explain how they would take medicines, and then it also asked them to explain, to show how they would demonstrate it, count out the pills. So in this case, so the yellow that you see there is the first question. Okay, how would you take this drug? Here's the label. How would you take this drug? The green one is show me how you would take this drug. So look at the difference between, explaining how to take the drug and how, and show, actually being able to show that. If you look at just the low literacy group here, 71% of that group were able to correctly say how to take it, but when they actually had the pills in their hand, only half that amount could actually count it out right and show them. So there's a big discrepancy about people think they know, but when it comes down to it, it's like, okay, is this with each meal or with just one meal? So with that as setting the stage for the whole problem about communications, I'm going to skip now to share a bit on a case statement. This is a program that we did called Let's Talk About Medicines, and they were essentially workshops that were offered to the community about how to take medicines. And the point of these workshops were that we wanted people to gain a better understanding of how to effectively use medicine, and also to develop a comfort level in asking a pharmacist questions. So I always like to think of, I don't know how many of you use Walgreens, but I'm sure some of you probably do. When I drive through Walgreens, I use the drive-through when I can, and you drive through and the pharmacist hands you the medicine, and what does the pharmacist say at the end of the conversation? Do you have any questions? So first of all, that's the wrong question. What the pharmacist should be saying, what questions do you have? That's a whole topic for another day. But you're standing there, you got 3 cars behind you. When you say it, the car over here can hear what you're saying, so you don't ask questions. Then you get home, or maybe you don't even at that point know that you have questions. You get home and you think, oh, the pharmacist is so busy. I mean, they're rushing around doing this. I don't want to bother them with questions. So we want to, part of this was to encourage people to ask your pharmacist questions because they want you to. They want you to take this medicine to use to help you. We've done 189 of these workshops since 2014, funded by various organizations, and they have they have actually gone so well that we actually have morphed into some different versions of Let's Talk About Other Things related to health as well. They use a workbook, and the workbook is I didn't bring enough copies for everybody, but I brought enough for you to at least for you to look at. And I'm just going to pass these around. So this is the Let's Talk About Medicines. And if any of you want to steal them, please do, because I don't want to take them back. And actually, I have another version, which is the one that we did for refugees and immigrants. So I'm going to pass this one around also. And you should be able to tell the title is the same, but you should be able to tell by the picture that this one is for refugees and immigrants. So this is the workbook, and it was done in a very health literate manner. If you look at that, you'll see that there's a lot of white space, that it's written in roughly a 6th grade reading level, that it's very easy to follow through, and is part of this workshop that we do. We do pre and post tests for these. And this is when we actually work with community organizations who invite their people in for a workshop. So, for example, a literacy council will invite their people in, and we'll have 15 to 20 people who will for an hour go through this workshop with us and learn about how to effectively use their medications. And then for those people who come, we give them a pillbox incentive. No. We have trained facilitators that do that. We encourage pharmacists to come, and they generally really like to, and it's really great when they do because there are always questions that non-pharmacists can't answer. So we're really actually putting more emphasis on when we go out to smaller communities, trying to see if the local pharmacy would be willing to send a pharmacist to participate. This just shows you and you can see it from the book, what the elements are. We talk about the different parts in the label, what's what, how do you know when to take them? How do you store them? What about over-the-counter medicines? What do you deal with prescriptions and the relationship between those? How do you remember to take your medicines? And again, asking your pharmacist questions. One of the elements is a card game, and that I'll just pass this around. I have only one of them, but this is I guess we'd call it a deck, so to speak. But this is what we do as part of these workshops. We go through some materials, and then we actually ask people to do this little game, which is really not a game, it's more of an activity, which asks questions like, what should you use to measure your liquid medicine? Who knows the answer to that question? A what? A spoon? Teaspoon? If they do, then you should use that. Yes, so the important part is that there are still tons of people out there who measure using a teaspoon. And somebody's teaspoon in their silverware drawer can be of any size. So using a syringe, using a little measuring cup, where are good places to store medicine? A cool place? What? My kitchen, is that good? Why not? Okay, when my wife's father used to store his medicine in the kitchen cabinet, and then he would leave the door open because that was the symbol to him that he had taken his medicine. So we try to teach people yes, light can damage medicine. Humidity can damage medicine, because where's another place that a lot of people have it? It's in their bathrooms. or over their sink, their kitchen sink, or over the dishwasher. So we try to talk about where you should store medicines. Don't put it in the freezer. There are still people that think that putting in the freezer, medicine in the freezer preserves it longer.
Also, I just have a comment. Just public areas of the home, like the kitchen. I guess it's probably like a kitchen cabinet is probably the best place because I've heard a lot lately of like teenagers that will go over to their grandparents' house and the medicines are in the bathroom, and they take the painkillers and the Ambien and all those sorts of things because they're in like a closed room. So if you can put them in a like public, I guess, common area, I guess you would say, in a home, that's probably the best.
And opioids, give a whole new dimension to this safe storage issue as well. But not, keeping them out of the way of people who should not be having access to them, whether it be kids or even other family members that may not be kids. They may be accessing things that they shouldn't be. So this is done with a lot of community partners. You can see the kinds of organizations that we work with there to do these sessions. And what we found was that there's really a lot of confusion, especially about when you take medications. And it's really a special challenge to those who speak English as a second language. Because just generally understanding, first of all, the wording on the label, and then secondly, exactly how to use that. They've been tremendously successful. This just shows you an evaluation that we did where we found that from pre to post tests that 21 to 56% more answered correctly about when to take meds. Now 56 is just over half, so we still got a lot of room for improvement there. And then when we asked people to identify parts of the medication label, that also increased. Still more room for improvement with that. And people have made comments like, "Oh wow, I never even thought about that. I never even thought about that it was bad to put my medicines in the, or to leave it in the car." Now you folks here don't have this problem, but in Wisconsin we do, in sub-zero temperatures for a day. So all those kinds of things really made people think about it. And there are some videos that go with this that are online about kind of how to take medicines. There's a little quiz that's also online asking people some of the same questions that are on those cards, actually. We've done a version of this, as I mentioned earlier, with refugees and immigrants. Much of it is the same, but we realized we needed to spend more time, for one thing, on talking about what is a pharmacist, what is a pharmacy, and where do you get your medications? Because depending on what country they came from, those systems are very different from us. In some places, you would get your medicines right from the doctor or the provider, whoever that might be. So there's some things we had to deal with there. Content, we used translations. We've shown samples of medications, and we really had to look at this whole culture issue here, just because we can't make assumptions about people and where. And you also got people among the refugee and immigrant community who can't read in their own native language, let alone read English. So there's a lot of individual situations there. So for that reason, does anybody want to read this to me? Oh, no, you can't read no, you can't read the logo. So anybody know what language this is? This is Karen. Isn't that interesting language? But so we've translated this, and as part of these workshops, we've done them in different languages, and we'll use translators during some of them. There was one actually where we had 20 people in the workshop, and we had 5 different translators talking during this one workshop. It was crazy, but we got done with it. So, and then this is Omar. Omar works at Hyatt Pharmacy that I had mentioned earlier, and he shared some tips that we thought were pretty good as far as dealing with refugees and immigrants in a pharmacy setting, some of the challenges.
I always look at our job as treating our family members, a brother, a sister, a mother, a father, a son, a daughter. If we believe that this is my sister, my brother, or a family member coming to me, I'm going to be giving them the maximum that I can provide. So I
we found that there was actually a number of pharmacists that were somewhat uncomfortable with dealing with the whole language issue because it's not necessarily, I mean, there are different systems in different pharmacies. That in itself is a really complicated issue on translation services and how you deal with, in this case, they were fortunate because they deal with a lot of refugees, and so they have a lot of people who speak different languages in their pharmacy. Oh, then there was a version that we did called Let's Talk About Pain Medicines. And I'm going to pass this around also. So this is basically just the opioid version of Let's Talk About Medicines. So a lot of it was storage and all that kind of thing, but then we also talked more about, you know, so people don't know what opioids are, which is so they don't know, like if they don't necessarily know that oxycodone is an opioid. I mean, they kind of get heroin, but so part of it is just explaining whether the medicines that they take are actually opioids, because we keep talking about be careful of opioids and the danger of opioids, and a lot of people don't even know whether what they're taking is an opioid or not. The risks that they have, and then again, the safe storage that we touched on before, which is how do you store those in a way that other people that shouldn't get to them don't get to them. And another part of this is also, what do you do when you're at the end of, you know, what if you've taken half the bottle and then you stop taking them? You know, how do you dispose of them? And there are a number of things. There's take-back days. There's all sorts of things out there, but it isn't the same from one community to the other. So we talk about those kind of things. So this whole thing, Let's Talk About Medicines, is a program that actually can be fairly easily replicated. And so we do have some information online. If this is something of any interest to any of you, there's some information online at wisconsinhealthliteracy.org under the What to Do or What We Do projects. But we can also talk about, you know, what isn't online and what information might be of help to you. So now we're going to move on to the prescription labels. And we're going to talk about patient-centered prescription labels. So what makes it patient-centered? Well, it's organized in a way that reflects how most patients seek out and understand medication instructions. So it's the organization, but it also really features the information that patients really need. And we've done a lot of work in this area and found that can be quite a discrepancy between what pharmacists want on prescription labels and what patients want on prescription labels and where. So we're going to do a little work on this. And so here's what I'm asking you to do. We're going to get some feedback from all of you on what you think makes a good prescription label. And so what I'm going to ask you to do is to work in groups of 2 or 3 or 4, whatever's convenient. And then when you figure it out, they'll come to you and get them. They're just one of those per group. Okay, so what you're getting here is a blank label. So it's just a blank label that you're going to design. And so actually, why don't we let you let's figure out the groups right now. So either 2 or 3 together, or 4, whatever. Okay, and then when you figure them, then one person in each group, if you would come up and get an envelope. You can. There is no hidden secret in the envelope. And so in this envelope are the pieces of information that are commonly on a prescription label. So what I'm asking you to do is to take these pieces and lay them out on what you think would be the ideal label on that piece of paper. Do you have one of the bigger sheets yet? Okay. Oh, here. Oops. So lay them out to what you think would be the best way to create what would be the best label. And if you want to draw any boxes on there, you can. You can figure out what you think would work, lay them out there, and I'm going to give you about 10 minutes to lay them out, and then I'm going to ask you to stick them on there. So lay out what you think would make a good prescription label. Now, two things okay, before you get too deep in this, listen to me for just a second. If there's anything in there that you don't think should be on the label at all, then feel free to take that and put that outside the margin. Stick that outside the margin. Okay, and just as a point of reference, there's one that says pharmacist SS. This is the pharmacist who dispensed the medication. Is it his or her initials? And there's another address, which is the patient's address. The one that says apartment something. Okay, so everybody with me, then figure out what you think would be the ideal, what label would you like?
The NDC number is a drug is a national number for that particular drug.
That's true. Because it's more specific. Sometimes we say you know, like the actual code.
Well, the correct answers that I have, you don't actually have in this HTTP labels.
Do you see like a diagram of the test?
Of my computer system that I'm using. It's going to give me an NDC, it's not going to give me the descriptions, all the bottles. And I don't think that would make that much difference. But we can add it on if we like. Or we like. How often is that? Unless it's the last tablet. Yeah, there is a possibility that we ran into this problem like last time with Tylenol and Tylenol. Remember, if the daughter who's going to fill out for her, the same. We just risk of putting it back in the phone call, right? But yeah, so they look similar. So I mean, it's a problem, but we can talk about that.
Now, this side should be more uniform.
Do we stick them on here or do we just set them on top?
Do you think that we do this? Is that the information of the patients? I don't find that that's, I think it's who builds this, right? They're just gonna look at it in the systems, right? Unless it's a controlled substance, like they're gonna be probably, I don't like to stress on that. So we can leave this one out. Yeah. So what do you think? You like it? Okay. Well then. And then. I mean, it has to be on the label, right? It was prescription drug law. You told me you want to just pass it. I don't know what it is. Well, unless you're taking it to a different pharmacy.
Yeah, no, I mean, it's definitely.
What if you lose your medication while
Are we sticking?
Yeah, go ahead and stick. Go ahead and stick them on.
Oh, where's my weight?
Oh.
Are we applying to the
Well,
law
it's the site first, so.
or just the?
Yeah, that's right.
To a state of lines or?
Because, I think the patient.
Yeah, we'll just look at lines is something that you don't think needs to be on the label. So if
This
it
was
is in the
the one that
line,
Dr.
it's
Martin
going to be
gave me
in the label.
I think that's important. Yeah, so the only thing is that see, this is important for us, though. But they can, I mean, it's.
That's okay, sure, as long as the content is inside the.
Wait, but here it looks like the job. So what's your name? What's your name here? I think it should go here.
You're very super expensive with it too. There's like $8 for the
Yeah, like,
We found this stuff in the back of our name. Can I take your picture? Oh, whatever. You are working. I know.
I'm gonna go to Dallas. She put me in the spot.
you want me to watch
Yeah, we have to talk about, I'm sorry, you want to take a look? Okay.
If you actually have studied the USD standards for patients and labels and pharmacies.
For labels, I'm not quite sure. There are definitely some USP standards, like for instance, on compounding
Yeah,
pharmacies.
there's a lot of,
Yeah,
yeah.
that kind of stuff we
You
review.
don't remember standards for like,
chapter like 17, 7, and 8.
this is 17.
No.
Okay. All right, you're almost done? No. Right. If you would like to change first.
It really doesn't matter. I think that it's going to be on the
You
page.
guys just about done?
Do you want to make it up or just?
Do you want to put anything else down there? You can put quantity and
Yeah, before I say.
Okay, Doc,
you do whatever you want.
get as many stuck down as you can in the next minute. And if you don't quite get done, that's okay, you can keep doing it as we talk.
If you were to lose you want something. But then again, with this shit. Yeah, exactly. And then have a patient's phone number. Oh, no. So my patient address is never, I never see patient address.
Okay, so let me, if you're still sticking, go ahead and keep sticking, but in the meantime, we're gonna ask a couple that are done to talk about their labels and why you did what you did. Any of you willing to do that? You guys willing to talk about yours? Okay, can you stand up and hold it and then explain why you decided to do what you did?
Definitely the name of the patient is very important. Also the prescription number, so if they call the pharmacist and they just put that by prescription number. Also the date it was showed, the name of the drug. And I really liked how it included the indication or the use of medication, so it's more blood pressure, that's not always necessarily on the label. And then the directions.
Of the pharmacy name and phone number is important, so they can call them the refills. Their doctor, in case they don't remember what it's for, that might help if it's like a cardiologist or something like that. They know it's their that for that thing, or so they know who to call if there are any issues with it. We put this just so they wouldn't share. Yeah.
Did you debate about whether that was, this is that little federal law requires, did you debate about whether that, put it on the label or not?
Yeah, we weren't sure. I mean, I think the language or the jargon is kind of complicated. So maybe just like counseling the patient, telling them, okay, don't share this medication, would suffice.
What about the rest of you on that statement? Did you put it on or not? You didn't put it on?
No.
Did you guys put it on? You did. What about you guys?
We put it on.
You put it on?
It's required.
It's not required by law.
We were, in our discussion, we just kind of talked about how people ask themselves questions before they will ask, someone else or a professional. And so if someone were to ask themselves, I wonder if I can just give, my niece this medicine because she doesn't feel good and she's had the same symptoms I had, then they try to play pharmacist. And so we just kind of put the label there to clarify if they had any questions. Because it happens all the time where people are sharing their medicine with something else. So we try to clarify that.
It becomes a balance between uncluttering the label and putting information on. And you have to decide, does the fact, if I put that on my label, are people really going to read that? And if they read it, are they actually going to not share the medicine because there was a little tiny type on the label? So those are the kind of decisions that get made. Okay, so did we hit the highlights there?
Expiration date, that's important. And then we really thought that the color of the tablet and the shape of the tablet was very important because a lot of times people will take their medicine out and put it in containers like the Sunday, Monday, Tuesday, Wednesday, Thursday, Friday thing. So they get confused, then they'll be able to revert to the bottle where it gave the shape and the color.
Okay. What else did you not put on the label?
We didn't put that patient's address because they know where they live. And we also didn't put the NDC or the pharmacist initials because that's in the computer. And we look at
The NDC code is a subject of controversy among pharmacists. So the project that I'm going to share a little bit of information about, where we're working with pharmacists to design new labels. Some pharmacists insist on having the NDC code on there. It is not required, but they insist on having it on there because it makes it easier for them to put the drug back into stock. So, okay, what about, probably maybe two more, could we just, you want to talk about?
Okay.
So I kind of maybe point out what you did maybe differently than what they did?
We did include the address because that's how we, when we're doing vaccinations, we confirm that it's the right person, and we don't have date of birth on here, so we confirm with their address. We did not include the barcode or the warning or the pharmacist because trying to declutter, and we did put the prescription number on there, and I know the barcode can be, you can scan it, whatever, but you can also hand enter the RX number. So if you need to look it up. But we were trying to keep, and we didn't put the NDC number on there either because we're trying to keep it clear of all the industry things and make it plain for the person to understand. And they want the direction, you know, they know that this is, I gotta take it, how do I take it? And a lot of the time, they just want the directions, like if they're putting it in little pill minders, med minders. And we did include the doctor's name because I know that my dad knows what his primary care's name is, so he knows, oh yeah, that doctor told me this, and he prescribes my blood pressure medication. So they can kind of help with understanding and remembering, okay, this doctor gave it to me, so it must be for this. You know, but it also has it on the
Sure.
We're trying to keep it as simple as possible and decluttered.
And some of the things you touched on here, so it talks about the difference from one pharmacy to the next. You know, some pharmacies use the prescription number and others actually don't. You know, like we worked with 3 main pharmacies on this project. One of them does not use the prescription number. So they put it on there, but it's really small type, whereas some of them, it's a big thing because it's what people, when they call in and say, I want a refill of this X medication. So there's a lot of variance from pharmacy. There's also a lot of variance from state to state on what's required on the label. So for example, in Wisconsin, the physician prescriber is required. It has to be on the label. But in some states, that's not necessarily I should speak now. That's not the case. So we have one more. We got time for one more. Would you like to talk about what you guys did a little differently?
We went ahead and put the patient's name. We did the patient's name and the address, and then the drug, and I would like to see the generic name cut in parentheses next to it.
Okay.
Because sometimes patients get, they get both, you know, they go back and forth depending on what's available from the different drugs.
And they think it's 2 different drugs.
Yeah.
Okay.
It's 2 different, that way they can see. We put the pharmacy name and the date that they got it filled, put the doctor's name on the side here. Then we put for the blood pressure, what it was for, and then how it's taken, and to be taken with food and may cause drowsiness underneath it. And then we put right here we put the description of the pill, because I think that's important. And we put the pharmacy name of the pharmacist that filled it. Because sometimes, you know, pharmacists are human too, that they might put the wrong prescription in the wrong container. At least they would know who filled it. I'm sure they would have that on there, but they were asking. We put the DNC code on there, also underneath there, just put on the side, just so that way it would be available. Quantity is 30, and then we put the refills and to be used by that date. And then the caution on the side, down on the bottom with the thing. And I think, you know, I might seem like it's cluttered or whatever, but I work in a hospital, and a lot of times patients just bring all their medications. It's got stuff spilled all over it. Sometimes you can't read what's going on. So it's better if it has more than, like, if it has a pharmacy name, a prescription number, but also the barcode. They would be able to call the pharmacy and get it. A lot of times, either that, and also to call the doctor to see what doctor prescribed it. Was it a specialist, or was it just their primary care doctor?
And a lot of patients don't even know the name of the drug. They just say the little blue pill for blood pressure.
Or if they see more than one doctor at a, you know, because now that's what it is. You know, you go to a doctor's office, you might not be seeing the same doctor all the time. So which doctor prescribed this to? Was it one they usually see, or is it just one that was filling in?
And a lot of our software, when we enter the name of the drug, that NDC number has to come up also.
Okay.
So that would help me ensure that that's the same drug.
Which gets into this issue of vendors. The software has something to do with this too, what the fields are, and that, I mean, it gets really complicated fast because drop-down boxes in the electronic medical record and all sorts of things, how some of those fields are populated. So that the cool thing about it, I think when all of you were doing this, you were thinking about what, I mean, you were talking about like the patient, stuff for the patient. What would the patient possibly need on the information? So it's all, that's a patient-centered label. So and I noticed it was also interesting that all of you put the pharmacy name at the bottom, or you didn't put it at the top. Did you put it at the top? Oh, I'm sorry. Okay, I didn't even, I guess all right, so more of you actually put it on the top than didn't. Okay, so another source of controversy, because that tends to be what the pharmacy wants. You know, they want their logo on there. So again, it becomes decisions on what is most important, where should it be on the label, and where is the patient going to look, and how do you unclutter it as much as possible, given that there's a ton of information on that label. Say that again.
Oh, because you said that a lot of pharmacists want their label on the bottom.
Right. They don't want it, no, they want it on the top. If I said that, I misstated. They want it up there so their logo is like the first thing that you see. Now, generally, they would prefer to have it up in the upper left-hand corner.
Well, I think it's more so that way they know who to contact the event they wish to refill if they have questions.
Sure. Well, they need the number. Obviously, they need the phone number for that. You know, do they need it at 2 a.m. when they're trying to figure out how to take the drug? Maybe not. Maybe it's good enough for it to be someplace else. I mean, there is no right or wrong here. The idea is to be thinking about why things are done the way they are, so I would love if you want to take these with you, you can, but I would also love for you to leave them with us, because this is stuff that we use to get an idea of this is all part of our research on what patients like. And even though you're all professionals in the field, you're also patients. So you know what you like and what you'd like to see on the label as well. So let's go on to, I'm going to touch a little bit more on this whole project, and I'm going to breeze through some of these slides. So really, there's a lot of research that shows that patient-centered labels work. So the work that we're doing, we are actually involved in a project where we are working with pharmacies to change labels to make them patient-centered. And we know that it works. We know that there's research that shows that especially people with lower health literacy, by making a label easier to understand, using some of the standards that were developed and announced in 2012 by the United States Pharmacopoeia, that it can improve adherence from patients, especially with those with lower health literacy, and especially with those who have really complex medication regimens, meaning they take lots of different drugs at different times. So we know that it works. And this whole thing with the standards really got activated with a white paper that was written in 2007. And then in 2011, California became the first to actually require some standards. They aren't the current USP standards, but they were some standards. 2013, New York adopted some language, and then in 2013, the USP standards formally came out. They were introduced in 2012 and then formalized in 2013. And then Utah, the state of Utah, actually adopted these standards that I'm going to talk about in just a second, and then they took them back because the pharmacists complained that they were confusing. And I think to some degree justifiably so, because the real issue in Utah happened with whether they had to do it or whether they could do it. And the standards said things like, the patient name should be at the top in this size font. It didn't say they must be, but yet the Utah Board of Pharmacy came out with some requirements that said you have to follow these standards, but the pharmacy standards were a little vague. So there's some work need to be done there. And then there's been some revisions of these standards over time. And most recently, this is that Target bottle that I talked about. And the great thing about that Target bottle was that it had a really big label, because the problem with labels is that they're little, right? So there's only a certain size you can make the font on a prescription label. This was the one that was done by the VA, and this is the most recent one that CVS has come out with. Some of you may have seen that announced. It was just in the last few months, actually. And the CVS uses what's called the Universal Medication Schedule, which is this thing right here that essentially shows you when to take them during the day. So that's the point of that. Rather than try to verbalize, take one in the morning and one in the evening, it's saying with that, now this causes a little bit of a problem for people who are night workers. But that's what their new label is. Now, what are the USP standards? Here's in brief. They're fairly complicated, but first of all, you're supposed to emphasize instructions and other information so important to patients. So you're really supposed to, it's kind of like what you were thinking about when you were doing your labels. What's really important to patients? And then improving readability, that's through contrast, white space. There's only a limited amount you can do with a tiny label, but larger type and simpler fonts, easier to read fonts. Third was give explicit instructions. So that is in your, what is commonly called the SIG. Take one tablet in the morning for high blood pressure. And then separate the dose and the timing. So that was in the example that you said take one in the morning and take one in the evening. So separating the dose and the timing. Including the purpose for use. So that is again, a little difficult because the pharmacist can only put that on the label if they get that information from the provider. So one of the things that a lot of pharmacists have told me is that they get patients that come in and say, would you put on there that that's for high blood pressure so I can remember that? And they can't do that unless that comes in from the pharmacist or from the provider, and they contact the provider and get that information. So that's a bit of a challenge. That's a work in progress. Whoops. And then there's addressing the limited English proficiency, so the translation piece and visual impairment. There's some new work being done in that area. There are some labels, some places that are actually done in Braille, for example. There are talking medication bottles that you put it on this little thing and it reads what's on the label aloud to you. And so there's some work, it again is a work in progress, but it's something that's strongly being considered. So this project that I'm working on, again, as a case study, it was in 3 phases. Phase 1 was where we actually called pharmacists and asked them about those USP standards that I just shared with you quickly, and said whether they could be adopted in Wisconsin pharmacies. And in general, the pharmacists said, we've never heard of them. But when they heard of them, they said, yes, they think that they could be adopted. They were a good thing. So then in phase 2, which is the orange one, which we just completed in December, we actually worked with 5 pharmacy organizations, 65 different pharmacy sites, and we worked with them to redesign their label according to these USP standards. Now, one thing we found was that they had different requirements. So like some of the things you said, some of them had to have the NDC number on there. Some of them didn't. Some of them had to have the pharmacist initials on there. Some of them didn't. Some of them had to have the prescription number in big letters. Others didn't have to have it in big letters. So people have asked us, well, why don't we just have a standard? Why don't we have this is what a label should look like, period. And this is the reason, because of the difference in pharmacies, what they need and want, and also to some degree the difference in the size of the labels and the difference in the printers that they use. Yes? Uh-huh. Well, the USP standards say that the purpose should be on there if it's available and if the patient wants it there. Be- no, no. So this is the problem. So that information isn't coming, for the most part, isn't coming through to the pharmacy. So the pharmacist can't just put it on there. That's the problem. No. And then the off-label use is a whole different thing, because there are some people that want it on there, and then there are other people that don't want on there what the medication is for. So, you know, again, like everything, it's just really complicated. So as far as actually how this worked, we set up an advisory council, and we actually happen to be very lucky because Epic is right in our community, the headquarters of Epic. So we have Epic involved in this, which of course has an influence on a lot of the medical records that are going on. We've spent a lot of time gathering patient feedback. Just you see here, that'll look familiar. We did some focus groups, and we had some people do this exercise and had them put together and explain. They, unlike you, had a lot more time to do it and to explain it, but explained what they liked and didn't like about labels. Patient Advisory Council has been consistent in sharing their thoughts about things, and they had lots to say. Just for example, this is Shira, who's a member of our Patient Advisory Council, and here's what she had to say.
And I also didn't realize that I was reading some medicine labels wrong until I went to the conference, which was good, so it was like on my daughter's medicine. I also realized that I'm not the only mom who does these things, so that was really comforting, because I thought, I was like, oh man, I'm probably like the biggest idiot here, I keep messing this stuff up, and everyone else had the same stories that I had too. And it's really comforting to know that there are people that care that there's problems going on, because a lot of times in life, you know, doctors, not anything, you feel like you're just, you know, you feel like everybody's just kind of going through life humdrum, and, you know, you might have a problem and you don't want to say anything, so you don't want to be that one that like whines about it or says something, and then you find out, hey, there is a problem, these people are going to actually listen to us.
I'm sure it was a perfect example of somebody who clearly had health literacy a little bit on the lower side. She had 2 little kids that every meeting she came to, they were running all over the place. I don't know how she concentrated on anything, let alone when she got home and was trying to figure out how to give medications. I mean, her life was complicated. So it's really helpful to have that kind of feedback. There was a label survey that we did where we asked people to go online and pick which label they liked and tell us what they liked and didn't like. And then this is the summary of all the things that we did with patients about what they liked and didn't like. They really liked the bolding, color, bolding, large font, white space, what the drug is for, kind of some of the things that you talked about. Most important information at the top. They wanted the name of the medicine, and they wanted the prescriber name. What they didn't like, and if you look down this list, a lot of this is what's important to the pharmacist. So they wanted the information for the pharmacist. They thought there were lots of confusing dates, the use by date, the expiration date, the dispensing date, all the addresses, and we talked about that a little bit earlier, that there are some pharmacies that use a patient address as identifier. There are others that don't. So it depends a lot on the pharmacy. They thought it was just cluttered, unclear directions. They don't like all capital letters used for where the directions are. And they didn't like the pharmacy information at the top. And other things came out of that discussion too, which, for example, one thing came out that the focus groups that we did were all in agreement that they felt like generic drugs were not as powerful and were meant for the poor. Now, that wasn't the purpose of what we were trying to do in the focus groups, but that was a very commonly believed issue for them. And then there was concern that those people with low literacy, you know, if they just don't read well at all, that they may not be able to read any label. And then there's the auxiliary labels, those little things that I had you include them on the labels, but you know, sometimes there's separate stickers on there, and there's a lot of research that shows that people totally ignore them. So that is an issue. And then we put these cute little diagrams on there, and a lot of them, the ones I gave you on the label, are make somewhat sense, but there are others like some that look like tire tracks that don't drive with this medicine, and just weird things like that. So we recruited the 5 pharmacies that I talked about here. We worked with teams to implement the new labels with those pharmacies, and here is the best example of one of those pharmacies. So you can see the before and after on the label. So this is obviously what they had before, Hometown Pharmacy. They had all this stuff going on. They had all this stuff on the side, which is one of the standards, is to don't write this stuff on the side, sideways. They had all this extra information down here. Here's the tire tracks down here. And look in this area, you see a whole bunch of numbers and dates and stuff that just were really confusing to people. So this is the after version. You'll see that the NDC number is still over here, but it's tucked over here on the side along with the manufacturer name. They wanted those on there even though they aren't required, but put it over because that's information that's helpful for the pharmacist. And they wanted to highlight because this number was really important to them, but they felt the most important was the name and the directions. So they're trying this out. They've asked some people to look at it, but even when you just look at it, you can see how much easier on the eye it is to read. But it also requires a willingness to give up, some of the information that might be cluttering the old label. There's a toolkit that pharmacists could go into. This address right here is where that toolkit is online, and that has if you're interested in looking at more of the standards that I talked about, those standards are listed there. There's some really good articles on that site that talk about patient-centered labels. So the evaluation, we did some patient surveys, and we found that 93% of people thought it was important that they be easier to understand. 83% liked the new label better or the same. And generally they found they liked the bigger letters, felt it was easier to understand, and they could find the information easier. We surveyed pharmacists. They felt that these labels could result in better adherence, fewer errors, and that the patients would be more likely to benefit from the medications. Here's one of the pharmacists.
Patients under pressure right there, and you're counseling them, and you're trying to assess that, and they've got their little 6-year-old that's grabbing a sucker that's on my counter that I've distracted them with. And they go home and they take a deep breath, and then they look at their vial and they're like, what does this mean? And they call me back. So we've seen a dramatic decrease in that. What does this mean? Call me back later. Because of, I think, both with the labels and then also with our simplification.
So one of the things that he said that was interesting was the callbacks. He said that they have really noticed since they went to new labels that there were fewer callbacks, which was great news for them because even though they want people to ask questions, they also don't want people to ask questions that have already been answered more than once. Here's the pharmacy manager from UW Health talking about their experience.
Our organization has a focus on patient care and health literacy and making sure people understand their current health care. And we realized with prescription labels that we hadn't looked at ours in the last decade to address whether they were appropriate, whether patients could understand them. So we knew this project was a good way to have a great opportunity to make sure we get the label updated, make sure people understand how they're supposed to take their medication, and hopefully have better health outcomes due to that. Well,
And it was interesting because the experience of changing the labels in a university, academic, medical center was totally different than an independent pharmacy like Hyatt Pharmacy. So, but did it work? Now, again, we weren't trying to prove that patient-centered labels work because the research has already shown that. But we did want to take the opportunity to look, if we could, to see if we could see any difference in adherence. So we actually took data. This is a little busy here, but we were able to get data from a state Medicaid health plan and compare that to data from one of the pharmacies that changed their labels. So we could look at this pharmacy's patients who were members of this medication, of this health plan. And what we looked at, the previous one talked about, we looked at asthma, hypertensives, antidepressants, and contraceptives. And we looked at this medication possession ratio. So again, we looked at when did they fill their prescriptions that they had? Did they fill them on an appropriate schedule? Did they logically have these medicines that they needed to have in their possession? You know, obviously we couldn't see whether they were actually taking them or not. And then we looked at the pre and post change in the medication possession ratio. And what we found was a significant change in the proportion of patients in the higher levels of medication possession ratio after the label change. In these three drug categories, asthma, hypertensive, contraceptives, in those three categories, there was a significant increase in the number of people correctly adhering to their medications as defined by this medication possession ratio. So that was really good news. And in the future, we're going to try to see if we can tie that into some way with health outcomes, falls, and that kind of thing as well. So now we're on to phase 3, which is, again, the other phase 2 is the pilot program. Now we're implementing this across the state at various pharmacies, we have 7 already signed up in this new round. One of the things we're working on is the SIG improvement, because that's an area that we really didn't work on phase 2 very much because it's very complicated. It has to do with drop-down boxes. It has to do with providers. One of the providers that we're working with said one of the big issues is that he thinks a lot of providers, prescribers, are not necessarily even aware of the problems of SIGs, like take 2 tablets twice daily. So even creating awareness to that issue. So we've got a SIG improvement task force, and Epic is part of this, so they're really being helpful on this, that we're working with us, and we're using the health literacy principles. Take one inhalation twice daily, changing that to 1 puff in the morning, 1 puff in the evening every day. So unfortunately, it takes more words, but it's also much clearer, again, if you're at 2 a.m. looking at that, trying to figure out how to take that medicine, you're much more likely to be able to apply that. There are lots of standard SIGs out there. These are examples here that were done by AHRQ. There are some translations of these that are done by California groups. So that's the story, and this is the story that ultimately came out about this project that kind of I think does a nice job of summarizing it.
New changes to your prescriptions are coming to local pharmacies. Melinda Jones joins us in the news center and what you should be looking for on bottles to make taking your medication easier. Melinda?
Oh, that's right. Mistakenly reading your medication bottles is actually a big problem. According to the United States Pharmacopeia, mistakes from patients misunderstanding labels to their medication accounts for 700,000 ER visits and 117,000 hospitalizations a year. Now these new changes are hoping to prevent that.
We all have busy lives, maybe you didn't think of that question when you get home and you're like, oh, I forgot to ask.
Those are the extended release therapies.
To avoid questions and taking prescriptions incorrectly, pharmacists are changing how you see your medication.
All the information is on there, same as it was before, but let's change the real estate so that the most important information is at the top.
Matt Mabey and his wife Kristen run the Hometown Pharmacy in Cottage Grove. It's one of 3 pharmacies in the state to change labels to help patients under new standards by the USP. Instruction for patient information is put first, and there are new label changes to make it easier to read and understand.
With the best intentions in the world on everybody's part, we are not communicating well enough. The patients are trying to understand how to take their medicines and take them correctly.
Not understanding your medication not only can cause confusion, but can send patients to the hospital. Wisconsin Health Literacy is sharing the new standards during their Medication Label Summit.
By better understanding the labels, they're more likely to use the drug as it's intended.
The group is partnering with 52 sites to test changes. They also plan to implement more modifications directed towards the visually impaired and patients whose first language is not English. For pharmacists, the changes give an extra peace of mind that their patients will be taken care of.
So that anybody that picks up that vial and gives medication to the ultimate end user, the more we can increase that possibility that those directions will be read correctly, the better.
Now these changes are new. UW Health, Hyatt, and Hometown Pharmacies just started implementing the new labels within the past 3 months. These are not required standards. Pharmacies volunteer to make these changes, and eventually Wisconsin Health Literacy hopes that all pharmacies in the state will decide to take part.
All right, Melina Jones of the News Center. Melina, thank you very much.
They didn't give me much airtime on that one. So we have a long way to go. I mean, there are some things that are really improving in this whole medication communications arena. The expansion of patient-centered labels, the things we just talked about, there are new options. The medication guides that go along with the medications, there's some products out there that are written in a very health literate way, even though most of them are not. Instructions for liquid medicines. There's a lot of work that's been done in that area, especially as it relates to pediatrics and kids taking liquid medicines. And there's a lot of tools out there like electronic pill reminders, apps, and things that help us remember to take their medicines. So there are things being done, but we still have a lot more to do. And what I want to end on here is to challenge you a bit with some things, because some of you, as you looked at some of this, thought, well, I'm not a pharmacist, or maybe you are, or I'm, what can I do? I can't change anybody's labels. So here's some things that you might think about based on what I've talked about today that you can do. Advocate for better labels in your health system or local pharmacy. The problem is that people aren't even aware of these standards that I talked about, but yet it's proven that they actually can be effective. And is something that people can really implement on their own. Include medication communication and staff literacy training. So if you're doing any kind of involved in any training, to be sure to include medications, because it's such a critical part of healthcare and such a problem area. Offer workshops in the community. This is the ones that I talked about, the Let's Talk About Medicines or Let's Talk About Pain Medicines. Provide pill lists, apps, or other things. What can you do to help people take the medicines? If, for example, they're not remembering, what they heard at the pharmacy counter, how can we help people to remember how to take them better? And then lastly, promote teach back for meds. When we talk about teach back, we talk about lots of different things, but how to take meds is a critical part. If your example that you cited earlier about the ring, if somebody had used teach back with that person, they would have instantly realized what the problem was, could have corrected it, and that would have never happened. So using teach back regards to meds. And then lastly, also train pharmacists in health literacy. So the pharmacists that are in your community, the pharmacists that are in your organization, what do they know about health literacy? I find that not a lot of pharmacists know much about health literacy. So, do you have an opportunity to do a little bit of a health literacy training with them? And this is a tool, actually, that is a fact sheet about health literacy for pharmacists. And if you have any interest in, I can actually send you this document, but it's really designed, this is just a segment out of there. How do you help low health literacy patients if you're a pharmacist? So that's the story about communicating about medicines. It's a challenge, but it can make such a difference in people's lives, and not to mention just how much more effective it can make the healthcare system. We got just a couple minutes for any comments or other questions that you might have.
Did you find yourself having to get the state board on your side whenever you were doing some of your work already in Wisconsin?
The state board, so that is a tricky one. So when we started this project, we contacted the Wisconsin State Board of Pharmacy Examiners, and they said they were interested, sort of. So they didn't say don't do it. They didn't say they weren't interested. They just really didn't want to get involved. Now in Wisconsin, My understanding is that the Board of Pharmacy really operates very differently from state to state. In some places, the Board of Pharmacy has a very tight rein on everything, all regulations and so forth, and others not so much. In Wisconsin, it's not so much. I mean, they still do regulations, but so what we did was we went ahead with this, we implemented this, we then asked for a meeting, and we went to one of the Board of Pharmacy Examiners meetings and shared what we did and what we found. And at that point, they said, wow, this is really interesting, you know, it sounds like good work, keep us informed. So that's kind of where we are on that. I mean, somebody has asked us, is there an intention to somehow regulate this in the future? And at this point, it's all voluntary, but it could be in the future. But that's, you know, that's going to be another challenge because all these pharmacies want to do different things. So we're very aware of them and as influencers. Yes.
So on the results slide, you said that, you know, the findings were significant.
Yes.
Do you have like actual raw data that we can look at? 'Cause, like, what was it like before versus after?
Yes, I do actually. So if you want to leave me a card or take one of mine and email me, I would be happy to send that to you. All right, the only last thing I wanted to share was that I forgot to mention this before, but as part of the Let's Talk About Pain Medicine program, we did 4 fact sheets in very health literate language, and I do have some samples of those here. So if you have any interest in picking up one or all of those, you know, feel free to do that as well. And thank you very much for your attention. Thank you for your advocacy.